Allow me to bring to you our global head of human healthcare practices, Dr. Vincent Grasso. Dr. Vincent Grasso, for those of you who may not know, it comes from Yale and Mount Sinai, a practicing physician who actually practices what he preaches. So very actively involved in opioid crisis management. Also, one of the things that distinguishes IPSoft, we often try to say, if you permit a moment of immodesty, I'd say, is our brain power. And I think that Dr. Grasso truly epitomizes that, being the program manager for NASA for International Space Station project as well. So let me just quickly have him introduce to you the problem that we are facing and how can cognitive agents truly solve this problem in our country. Dr. Grasso.
Thank you, Chetan, and welcome. I have the great privilege and pleasure of leading the healthcare practice, but I also practice in an interdisciplinary clinic, a multi-specialty clinic in Newark, New Jersey in the inner city. And I've been able to use that experience to fine-tune some of our assumptions as to how the asset that we have, Amelia, and other attributes can bring value to our patients. What we have up on the screen is a beginning of an analyst risk assessment tool for our medical assistants. What you see is an opioid test and a pre-diabetic test, but there are many more: hypertensive, risk assessment tools. You know, there's a whole plethora of tests that we must engage with our patients to gather the correct data. But what we'll walk through first is the opioid test as an introduction of our digital assistant for the medical assistant space. Just some quick statistics. 20% of the population in the United States suffers from chronic pain. So if there's 1,000 people on the webcast, about 200 have chronic pain, which means you could be exposed to an opioid. If you're exposed to an opioid, about 10% of those patients wind up having problems with getting off of them. So it's a massive number. And the Society of Actuaries reported $630 billion at economic cost, forget the human suffering, over the past 3 years. So it's a massive problem. So let's look at the opioid test that we have here. And what you see here already is a bifurcation, because Amelia is multilingual. My patients that we treat in Newark primarily speak Spanish. I speak Spanish most of the time when I'm in there. So you have to be able to be sensitive and deliver this interface in a multilingual environment. So there is a Spanish and English available component to it. Can you select the English, which you did? Are you male or female?
Male.
How old are you? Yeah, 35.
I'm 35.
Now think about why this is an important question. What happens if you were 16? If you're 16 and you're going through this environment, you're a minor. If you were a minor and you were exposed to some situations, you'd have to be placed into social services at a different place than if you were an adult. So a lot of this data is really being followed on the back end on decision trees. Now, look at these questions. A family history includes your mother, father, and any brothers and sisters. You'd be surprised if you ask someone about their family history, they may think a third cousin is an applicable response. Yeah, a third cousin had diabetes, but that's not really what we mean by family history. So there's a qualifier that comes first to define what the term means so that the answer is more accurate. If you ask someone, did they ever have a mammogram? The real question that should come first is, do you know what a mammogram is? Because you can answer the question yes or no, and that doesn't mean that you understood what the question really was. That's part of the verbosity of what we have. Now, as everyone's going through these questions, there's social questions, there's substance abuse questions, there's a personal histories, family histories, and this comes from the CDC's recommendation for these 11 questions. We didn't make these up. There's a national standard for how these questions arrive. And at the end of the day, do you have a personal preference? This is really an important question. If you've been exposed to pre-adolescent sexual abuse, you really need to be plugged in to see some of the social service and mental health people in the organization. What you saw before was Amelia getting access to systems of record. Why this is so empowering is the following. As you're asking people these questions, and they're not in the office, they could be home before the visit or after the visit. If they claim that they've had mental illnesses, depression, anxiety, et cetera, you would access the scheduling system of record, and you'd be able to offer an appointment while you're doing this process. So that while this is gathering data, in the back end, it's accessing systems of record. so that you can in fact engage and perhaps schedule the patient in the same engagement. There's massive efficiencies in that. Do you suffer from depression? So this is a very fortunate patient that they had a score of 5, which places them into the moderate risk category. Remember, in healthcare, when we engage with patients, we think of things as emergent, urgent, or elective. That's what you do in an emergency room. When you assess people from these parameters, there's high risk, moderate risk, and low risk. You need different resources thrown at a high risk patient. So the exam itself is interesting, but it's what you do with the result. That's why it's so important to have access to these systems of record to carry the ball further down the road.
I think the example that you were sharing just yesterday, you were discussing with me one of the hospitals that you had experience with.
Sure. Yeah, so think about the large hospitals in New York City that have millions of patients. If you have 5 million patients in your network and 20% of them have chronic pain and a percentage of them are being prescribed opioids, there's a big number of people that you need to assess from a risk perspective. And unless you have a combination of a digital employee and a human employee, how would you in a month be able to get access to 500,000 people, get data offsite, 24/7, multilingual, omni-channel, and provide that data back to the population health folks, the CMO, the chief nursing? How would you do that unless we worked in this kind of hybrid environment? So that's really the power of this, that it scales, and there's massive efficiencies of scale with this.
Thank you very much, Dr. Grasso.
Thank you. Thank you all.